Good afternoon, everybody, and thank you for joining us for another one of our MAG free educational seminars. Today we have with us the very lovely Dr. Slava Poel, who is an anaesthetist and interventional pain specialist. Slava has been working for many years in Melbourne, but he's lived and worked elsewhere as well. And his recent accreditation as a pain specialist is a wonderful addition to our panel. The combination of anaesthetics and pain management is a very powerful combination, and pain is, as you know, in this industry, something that's becoming more and more brought into question in assessments and in relation to settlements for matters. So it's certainly something we need to be very involved with. I have had a look at this presentation beforehand. It is very interesting, and I know you're going to get a lot out of it. May I ask that you please keep yourself on mute during the presentation so that noise from your home or office does not interrupt the recording or Dr. Poel's speaking about this topic. There will be a time for you to ask questions at the end of the session, but if you have to go before the session's finished, you can type your questions into the chat and I'll make sure that they get answered. So thank you again for joining us, and without further ado, over to you, Dr. Slava. Thank you.
Hi, thank you. Thanks, Michelle. Thanks for that intro. I'm a pain specialist. I've worked in pain for about 7 or 8 years, but has only recently decided to formalize it and get my specialist qualification. So I am a fully fledged specialist pain medicine physician, as the faculty calls ourselves. And yeah, so thanks for joining. We're going to talk about pain, about how it's treated, about what it is. This is the overview. And so I'll just quickly run through how we'll structure this. We'll talk about pain and the definitions of pain and any controversies that still remain. We'll talk about pain as a disease in its own right versus a symptom of another disease. We'll talk about different types of pain as they're currently understood. We'll talk a little bit about how to and whether it's possible to verify a subjective pain report, not something that pain specialists talk amongst ourselves a lot, but I thought that talking to legal professionals, that would be something that could be interesting. We'll talk about pain vulnerability and what makes one person transition from acute pain to chronic while the other one goes on their merry way and recovers. We'll talk about some barriers to recovery and rehabilitation after an injury. We'll talk about pain as a kind of top-down, multi-dimensional construct as opposed to just the sensation. And then that will kind of lead us into what is a unicorn creature, a pain specialist, and then talk about treatment of chronic pain using a real-world example. So this is... let me just move this, sorry, just one second. So this is the official definition of pain as per International Association for the Study of Pain. It's a little bit of a mouthful, and this is the most recent version of it: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. There's a few issues with that. It's been criticised fairly widely, but some of the criticisms are the overemphasis on tissue damage. And this is something that those of us who work in pain know very well. The tissue damage is neither necessary nor sufficient for pain. It defines pain as unpleasant. We know that pain is not always unpleasant. There's many other criticisms, and the main one really is that this description still does not provide an operational definition of pain, meaning that it doesn't really lead us in any useful way to identifying it, measuring it, and testing it in any repeatable way. Now, this is it's a very old image. This is the first sort of attempt to provide a mechanistic explanation of pain. Descartes had a go at it back in 1644 in his Principles of Philosophy text. And so essentially what he conceived, as you can see in the picture, is that the body has sensors out in the periphery that capture the stimuli, send them towards the brain, which then initiates protective behavior. And this was a pretty pretty revolutionary at the time. Not many people were thinking about the connections between brain and pain. So it's quite an attractive way, an intuitive sort of way to think about pain that many people still use even now. And even though it's not strictly speaking incorrect, it's certainly an incomplete picture of what pain is. A little bit of a busy slide, apologies. So this is an attempt to provide a more sort of detailed mechanistic explanation of what pain is, 2.0, pain 2.0, if you like. So the thing to look at on the and the picture on the left is that there are three different pathways, one in red, one in blue, one in green. The one in red is the ascending pathway, so it's bottom up pathway. And then the green and the blue pathways are descending pathways. They're top down, from the brain down to the periphery. So, so the ascending pathway, you could see if you look at the shoulder region in the picture. So it starts with this sort of specialized sensory nerve endings that detect potentially harmful event. And then the signals are then passed on from that body region to the spinal cord and further up into the brain. And the important thing about this is that at this point, these signals are not pain. They're just signals, even though there's a big arrow there that says pain. At this point, it's got nothing to do with pain. It's just electrical activity in a nerve cell, nothing more. Now, top down, there are two pathways. So in blue is something called descending inhibitory pathway. So it's a pathway that basically helps modulate and reduce pain signals. It turns down the volume, puts a lid on the pain signals, if you like. And so we think the reason for the existence of that is to allow the organism, allow the body to function despite the injury and respond in an effective way to a danger source. There is also a pathway in green that goes from top down, and that's a descending facilitatory pathway. So that does the opposite. It enhances the pain perception. Why do we need that? Well, you can imagine it would be beneficial for protecting the injured areas in the initial stages, but of course it becomes problematic later on when this pathway does not turn off or amplifies, in fact. And so according to this view, the final pain experience is kind of an interplay between these three pathways. Okay. So the current and most recent view of what pain is, I call it pain 3.0, is a little bit counterintuitive, but it's probably the most correct. And in that view, pain is an opinion, if you like, of the organism's state of health rather than just a reflexive response to an injury. Okay. So in other words, pain is going to be felt whenever the threat is considered sufficiently serious by the body surveillance systems. Okay. Or in other words, you can say pain will exist when there's credible evidence of danger. Okay. And that evidence is greater than the credible evidence of safety. So if the body perceives something to be credibly dangerous, pain will arise in those circumstances. Okay. And the most famous example of that is this, call it man in the boot. Man in the boot case that was written up back in 95 in British Medical Journal. And this essentially involved a builder who tragically jumped down onto a 15-centimeter nail. Kids, don't try this at home. He was brought to the emergency department. He was in agony. Smallest movement was painful. He was treated with powerful painkillers, opioids, midazolam, which is a sedative. The nail was eventually removed from below, and when the boot was removed, it was found that the nails actually penetrated between this gentleman's toes. Okay, his foot was entirely uninjured. Okay, so that is an extreme but a good demonstration of how the body will just generate this experience of pain when it considers the danger to be credible. Okay. So very simply, this is how we think about pain in terms of its temporal relationship. We're divided into acute and chronic. Acute is typically anything that lasts less than a month. It has an obvious tissue injury or disease process of some kind. It's a protective response, and in that sense, it's adaptive, okay? And it generally resolves. Chronic pain is something that we arbitrarily define beyond 3 to 6 months or beyond tissue healing, okay? And we don't think it's got a protective function that we can recognize, and in that sense, it's maladaptive, okay? But in actual fact, there's no magic threshold where pain sort of moves from acute to chronic, and this is just part of a continuum, okay? These are the three most common mechanistic descriptors or types of pain as we currently understand them, okay? So at the top is nociceptive pain, and that's pretty familiar phenomenon. It's pain due to tissue damage and the activation of this pain receptors that we saw in the diagram above. And this is pain that would result from things like fracture, burns, etc. Next up is neuropathic pain, and that's pain that results from damage or dysfunction in the nervous system. It feels different, so people describe it as burning, tingling, shooting. And it's the sort of pain that will result from a cut nerve or diabetes that affects the function of little sensory nerves in the feet and hands, or pain after a stroke, okay? And then the most recent addition to this mechanistic descriptors is nociplastic pain. So it's a very recent definition. And it's the type of pain where the processing of pain signals, the actual pain system, is altered, okay? There's often no obvious tissue injury, or the injury has long resolved. It's often widespread, and it does not respond well to typical pain treatments. There's a formal definition that has lots of criteria, but I'm not going to go through them now. Suffice to say that it's a strange kind of pain, okay? So if we think about pain as an alarm, okay, it helps to then think about why the alarm malfunctions so often. You know, why do people go from acute pain of surgery or injury to this chronic pain that they have to endure for months or years? So if we accept that pain has a protective role, okay, then we know it's acting as an alarm system, and what it does is it prompts action, basically. Someone feels pain, it prompts them to act. And that action is usually something that's directed at maintaining physical and mental integrity, okay? Now, we know pain is protective because people that do not feel it, people that are born with congenital insensitivity to pain, it's a recognized syndrome, will very rarely survive beyond the age of 25. Okay, so pain is truly protective. It's an evolutionary important protective mechanism. Okay, so this alarm system it's a bit of a strange fruit as far as the alarms are concerned. So if you compare it to other senses like hearing or smell, okay, other senses will habituate, they'll adapt and turn themselves down. So if you're hearing a background noise that's annoying you, over time, that background noise will fade, okay? Pain does completely the opposite. It sensitizes, okay? It just continues to scream louder and louder and louder. And that kind of makes sense. If you're injured, you don't want your alarm, which is pain, to turn down over time just because it's been a certain period of time. You want it to scream louder and louder and louder so that you will attend to what is posing danger to you, okay? The alarm is also very, very sensitive. It's highly sensitive, in fact, so sensitive that false alarms are preferable to missing a real threat. Okay, so we'll generate lots of false alarms in order not to miss one real one, because the real alarm may be the real threat may be the last one you ever feel. So it's important that the system is highly sensitive. It learns very, very fast, okay? So because you need it for next time, okay? A threatening event occurs. It has to be very adaptable because you can't possibly pre-program all the possible, painful life events. So it has to be adaptable and learn what is painful and what not, okay? And so the challenge is with this alarm is that it's prone to learning from events that were meant to be temporary, transitory, okay? And together with the other features listed above, you could see how it would be prone to malfunctioning. So this is a big one. Is the pain a symptom or a disease? So most, up until very recently, we've been looking at health through a classical disease model, okay? And in that disease model, pain is just a symptom, okay? The classical disease model is sort of a biochemical mechanistic approach to understanding illness, where the disease is attributed to a specific identifiable cause, fracture, infection, etc. And so then the resolution of this cause should just automatically lead to resolution of a symptom, which is pain. And so if we accept that, then immediately conundrum arises because we cannot account for pain that persists beyond tissue healing. Okay, so someone's had surgery, 3 months, 6 months down the track, pain is still there. The classical model that we've used for several hundred years just doesn't work there. Okay, so the predominant view now is that pain is actually a disease in its own right. International Association for the Study of Pain and World Health Organization have reclassified it as a disease in its own right, and the 11th revision, most recent revision of the International Classification of Diseases Manual also categorizes pain as a distinct health condition. Okay. Now, if you try and treat pain as a symptom, again, the conundrum will arise because there's nothing to treat in a sense, according to the old model, because the original disease process will often not be able to be identified or has resolved, like a fracture that has resolved, pain persists, okay? So some common examples that we see in clinical practice, phantom limb pain, okay, which is pain in an absent limb, okay? There's no limb, so what's that about? Where's the pain? Chronic pancreatic pain, so people that suffer from chronic pancreas pain will continue to experience that pain after removal of the entire organ. So, removal of pancreas, pain still persists. Okay. CRPS is a condition some of you may be familiar with. Lasts years after an injury resolution. But again, cannot be accounted for by the old-fashioned biomedical model. Fibromyalgia is another one. It's just sort of this widespread pain associated with poor sleep and cognitive dysfunction, and can often be seen after minor injuries or low impact car injuries as well. And this is the pain is widespread. It migrates from one spot to the other depending on time of the week, time of the month. Again, no clear trigger, no localizing anatomical pathology, but the suffering is real. So all of these sort of challenge the biomedical model that we've used for a long time. So again, this is not something that pain doctors talk about a lot, but since I'm talking to legal professionals, I thought this might be something that we want to think about. So is persistent pain report verifiable? Someone comes to you, they're reporting pain. Is it real? Since we can't see it, is it real? So there's a few tools that are emerging that are attempting to answer that question. These are not tools that are available in clinical practice just yet, okay? And all of them are trying to look for this kind of pain signature, okay, that can be mapped onto the patient's report, okay? So one of them is a functional MRI, which is a type of MRI scan that measures brain activity by detecting changes in blood flow, and these changes in blood flow will happen when the region of the brain is active. So we know where the pain processing occurs roughly in the brain, and if there's increase in the blood flow, we know that this can be correlated with a reported pain experience. There's something called infrared spectroscopy, where infrared light is used to infrared light is shown into the tissue, and then the absorption and reflection characteristics of the light are measured, and there is evidence that the changes in the light that you get back, you can derive a signature of pain from a tissue that you're looking at. So that's actually been done locally here in Adelaide, University of Adelaide, I believe. And same with the pain HS, which is a local invention. It's a blood test combined with imaging technology, and it looks at biomarkers, specific markers on the immune cells that may be related to pain. So all of these, so trying to provide an objective measure of pain severity, but still in experimental stages. These are not available yet. So what is available are a couple of things that are commonly used in in clinical practice. One of them is nerve conduction studies. You may have come across these. So these are generally performed by neurologists, and they evaluate the function of the nerve by measuring the speed and strength of the signals traveling up and down. And that is often used to confirm or rule out a neuropathic process. So pain due to injury or disease of the nerve or the nervous system. Okay, there's something called quantitative sensory testing, or QST, is done a little bit less often, and that will assess the nervous system response to various stimuli, heat and mechanical stimuli. And it can also help you identify some abnormalities in the way the pain is processed. Okay, when the tissue is exposed to different stimuli. Okay. I think I've got one more. So there's nuclear medicine scans as well. These are quite commonly used. So you inject a radiotracer into the bloodstream, and these emit gamma rays. And these gamma rays can be detected by specialized cameras, and you get pictures that look like this. And so if you look at the one on the right, there's this accumulation of this radiotracer in the person's foot that then is interpreted to mean, so it could be a fracture, it could be infection, etc. So these are quite commonly used. You can also use clinical signs to verify someone's pain report, okay, subjective pain report. So these are called Waddell signs, okay. They're behavioral signs that look for inconsistent findings, basically. So any behavior that doesn't align with the reported pain level or impairment. So for example, someone may be reporting severe mobility limitation, but then is observed to move freely when the person believes they're not being watched, okay? There's simulation signs. So there's something called the straight leg raise, where we literally just raise the leg straight up in the air, and we use that to try and diagnose sciatic type pain in the leg. And so sometimes the person will report severe pain when the leg is raised in the sitting position, but then if you lie them down and do the same thing, they're not reporting pain. So that would be an inconsistent finding and suggestive that perhaps the pain report is not genuine. And then there's the good old distraction signs. So someone who will vocalize and sort of dramatically withdraw when you try to examine them, but then, with distraction, the same, this behavior will disappear. Okay. So having talked about this transition from acute to chronic, it's good to think about why some people will develop chronic pain and others won't. And we generally divide these factors into biological, social, and psychological. Okay, so from a biological perspective, there are some differences in the genes that code for chemicals involved in pain signaling that can make a difference to how someone experiences pain. Okay. History of pain disorder, so someone who's previously experienced chronic pain or multiple episodes of acute pain, like multiple fractures and multiple surgeries, sensitizes the pain system and puts someone at greater risk of developing chronic pain later down the track with further new injury. And down the bottom, there's comorbid conditions. Comorbid means on top of something else. So these are conditions like common ones will be diabetes, obesity, or autoimmune conditions like rheumatoid arthritis. And it is thought that inflammation, this ongoing inflammation that's involved in, say, rheumatoid arthritis or even obesity, will increase the pain sensitivity and lower the thresholds for increasing pain, for experiencing pain. Again, busy slide, I'm sorry. So the psychological vulnerability is very important, something that we very commonly see. We know that psychological distress is strongly associated with developing chronic pain. People that are showing depressive symptoms before the injury are at twice the risk of developing persistent pain. We know that anxiety can amplify brain responses to painful stimulus as well. And so depression, anxiety are very, very common and ever-present risk factors for developing chronic pain. Catastrophizing is a type of cognitive distortion where a person comes to expect the worst possible outcome. And we know experimentally that the mere expectation of pain, even before a person is exposed to a stimulus that's painful, inside in the brain, the pain processing areas are starting to be active just in anticipation. Okay, and so as a result, the threshold for experiencing that pain is lowered. Okay. Fear avoidance is a term that we use to describe avoiding of activity in expectation of pain. Again, like we just said, expectation lowers the threshold for experiencing pain. So a person would then find that innocuous activity, like leaning forward to pick up an object, is experienced as painful, which then provides further reinforcement and learning, and then you just get into this kind of loop of feedback and feed forward sort of loops that entrenches the pain experience. Onto the social vulnerability. So it's very well established that people from low socioeconomic backgrounds experience more pain, more chronic pain, more mental illness, 2 to 3 times more likely to report chronic pain. That's huge. We know that people with strong social networks tend to experience less pain and improve faster, showing better outcomes. We know experimentally through these functional MRI studies that social pain, and what I mean by that is this the quote unquote pain that we feel from being excluded or rejected, will activate some of the same pathways that are activated when we experience pain. Okay, so it's not a probably coincidence that we call it, social pain or heartache, because it's just it activates the same type of brain networks. Okay, childhood adversity is a huge one as well. We know that children and adolescents who are exposed to adversity, and that can be obviously physical, verbal, sexual abuse. Poverty is also a type of adversity, neglect. All of these will produce lasting brain changes, okay, both in terms of structure and function. You can actually see them on imaging, okay. And some of these areas will be involved in stress and pain regulation, and so we will very often see people in pain clinics who have had some kind of childhood adversity. If you just ask about it, it's almost always there. So these vulnerabilities, the psychological, social, and biological, have been sort of formalized into this flag system, okay, which then can be used to identify people with barriers to recovery. Okay, I don't know, some of you probably would have heard of these. So yellow flags is a common one. They're the psychological barriers to recovery. So these are people who will develop anxiety and believe that they will never recover. Red flags tend to be serious health issues. So, for example, like a worker with a severe back pain and signs of nerve compression and fracture. Blue flags we call workplace perceptions that can impact return to work. So this will be someone who considers their job to be very physically demanding and lacking in support from their employer. Black flags are to do with social and organizational barriers. So this will be someone who's involved in protracted compensation disputes, or perhaps have an adversarial relationship with their employer. It's a very well-known risk factor for prolonging pain and disability. And orange flags refer to psychiatric conditions that need specialized care. So things like major depression, personality disorder, or PTSD is another one. And they'll work mainly through ability to engage in rehabilitation. Now, we also now talk about meaning of pain as a very significant kind of player in in how people perceive their pain and how they recover from an injury or from other noxious experience. So we know at a mechanistic level how the brain can put a lid on the pain signals. We've seen those top-down neural pathways, but that leaves open the question about what actually activates those descending top-down lid. Okay, why does one person able to activate those innate sort of protective function whilst the other one does not? Okay, and so that's demonstrated in a paradox whereby 37% of people injured will present to emergency department with absolutely no pain. Okay, same injury, no pain. A gentleman called Henry Beecher, who studied wounded soldiers in World War II, has also noted that the intensity of suffering seems to be largely determined by what the pain means to the patient rather than by the actual injury. And so a good example would be something like, if you can imagine an optimistic person that breaks their arm mountain biking whilst they're celebrating their weekend away with friends. Sorry, they're celebrating the promotion on the weekend away with friends versus a pessimistic person who sustains the same injury riding a bike from a monotonous job that I don't like to a home on which they're behind on mortgage repayments. So these people are likely to have very different pain experiences because it means something totally different to them. Busy slide, I'm sorry. And so the purpose of this slide is just to reiterate what we've talked to above. So on the left, this little box is a painful injury, so an injury or stressful event of some kind on the background of the vulnerability that we've discussed. And the green boxes are basically a pathway or trajectory in someone who interprets their pain to be controllable, time limited, understandable, and ultimately harmless. Okay, this person is much more likely to have a trajectory whereby they recover and go on with their life. Whereas if you look at the purple boxes below, this is someone who interprets their pain, same injury, but interprets their pain to lack meaning, to be uncontrollable, to be dangerous, and the trajectory is likely to be something quite different with prolonged suffering and disability. Okay. Now, are we really up to that? Yeah, we're up to that now. So what does a pain specialist do in light of all that? So we come from all sorts of backgrounds. Some of us are anaesthetists like myself. Others will come from a psychiatry background, surgery, rehabilitation medicine, general practice. We're generally involved in assessing the pain across multiple dimensions, like we talked before, the biomedical, the social, the psychological, okay? And then formulate an appropriate management plan and then leverage and coordinate the expertise of our allied health colleagues, okay? Generally, pain specialists will have extensive knowledge of pain pharmacology. Some of us, like myself, will have expertise in interventional pain treatments as well. Okay, so this is a real world example. This was a patient of mine, de-identified from a few years ago. And we'll just go through his injury and his journey over the next 18 months. So this was a 50-year-old carpenter, single father of two, who sustained involved in a workplace accident that involved a circular saw with a horrible amputation of several of his fingers and a thumb. Immediate post-operative course was pretty stormy, lots of pain that was difficult to control. He required reoperation until surgeons felt that there was his injuries were stable from a surgical point of view. So immediately with someone like that, we can identify 3 risk factors for persistent post-operative pain. So reoperation being one. Difficulty with controlling post-operative pain is another risk factor for ongoing pain afterwards, and a traumatic injury is a third one. So this is someone that you can predict just from reading the story is going to have is likely to have problems. So when this patient was assessed by myself in the clinic, there were three sort of diagnoses that we were able to make. One was CRPS. Okay, he had out of proportion pain. He had touch sensitivity, color, temperature changes, and swelling, which are all required for to make the appropriate diagnosis. He had phantom limb pain, so he had phantom finger pain, I should say. So he had pain in the fingers and a thumb that was amputated, and he had sort of features suggested with post-traumatic stress disorder. So he had intrusive thoughts about the accident. There was sort of features of hyperarousal, and he displayed lots of avoidance behaviors related to traumatic events. So avoid the noise, avoid industrial sites, things like that. So from the assessment, we spoke about the flags. I mean, these were his flags, potential barriers to rehabilitation. So orange flags, which are the psychiatric conditions. So there was a diagnosed PTSD. He displayed this catastrophizing sort of negative thought patterns about how things are going to go for him from now on. It was quite helpless. The yellow flags, which are the psychological and the social. So he expressed to me, this loss of caretaker role for his children, loss of professional role, leading to quite significant demoralization. There were financial concerns, uncertainty about future employment. These are all things that these are all factors that if are featured quite prominently, tell us that there's likely to be difficulty with treating someone like that down the track. And black flags, this occupational. So this gentleman expressed perceived lack of support from his management. So following assessment with me, he's gone on to undergone a multidisciplinary assessment, which involved psychologist, physiotherapist, and an occupational therapist. So psychologist has confirmed the PTSD symptoms that I initially identified. They went on to confirm and identify the triggers for these symptoms, as well as identified this sort of cognitive distortions that this gentleman displayed. Okay, the physiotherapist assessed the patient with respect to the range of motion, the strength, the functional abilities, and sort of establish the baseline for treatment and planning. The OT normally get involved with these injuries. As you can imagine, there's a big impact on everyday functioning. So the OT identified specific limitations with activities of daily living, such as dressing, cooking, driving, and this was this gentleman's dominant hand, by the way, so it was quite impactful. The OT identified other barriers in daily routine like pain, fatigue, stress, and noted that the pain was impacting this gentleman's cognitive functional coping as well. And all of these then provide kind of the blueprint for treatment. So this is what his treatment plan looked like. So after the multidisciplinary assessment, we all meet together again, discuss what we find, discuss what our goals should be and the time frame, and also discuss whether whether the patient is someone we can easily work with, or whether there's a difference in the approach is required. So the role of a pain specialist with someone like that is trying to support, to essentially try and reduce the pain intensity to support these rehabilitation goals. Okay, and we do that by introducing medications, pharmacotherapy. Some will be relevant for phantom pain, some we use for CRPS, and then there'll be medications specifically for post-traumatic stress that can be utilized. Occasionally an intervention can be useful in the form of a nerve blocks, etc. And we also provide quite a bit of pain education as well. NOT then gets involved, and one of the things that an OT does is they gradually expose the person to their feared activities. A big one for this particular person was fear of water. As soon as he heard water on open tap in the background, he was ready to run for the hills because of how sensitive his skin was to water. Okay, so the OT then works by desensitizing the person to this triggering stimuli, and it's a very, very slow process. The OT also provides the patient with adaptive tools. Like this particular patient required modified cutlery, so that he can feed himself 3 times a day. And then the psychologist will usually get involved with the person like that. And some of the things that they do is something called cognitive behavioral therapy, okay, which is a way of reframing and reappraising the patient's beliefs and thoughts about their injury. They'll teach them mindfulness and relaxation techniques so that they can kind of cope with pain flares at home and at work. And PTSD will require specific treatment, and EMDR is a type of treatment aimed specifically at PTSD, and it's a form of kind of cognitive reprocessing. Okay. So this went on for 18 months. We would see him at least once a week. The team would meet twice a week to coordinate care, discuss challenges. And so 18 months down the track, this patient's done actually quite well. Okay, there were significant improvements in his hand function. He was able to perform essential tasks such as cutting food, typing. I believe he was driving, back to driving as well, which obviously contributed to enhanced independence. He went back to some of his hobbies and social activities, which improved his overall quality of life. And when I last met with him, he was making plans to return to work in a modified and a supervisory role. So this was a good outcome. I'm going to stop there and I can take questions, or I can take questions offline as well if people want.
Lovely. Dr. Slava, that was really terrific. Thank you so much. It was very well paced. And as I said at the beginning, I'd read the slides before, really, really helpful. Now, I had a couple of questions from people who've been unable to attend today, but as I suspected, 2 of them were indeed answered already. Just for your interest, one was in relation to nausoplastic pain. It was an insurer's case manager who had asked that often in medico-legal matters, they have a claimant who has been through treatment for their injury, but they continuing to swear that they have pain which restricts them in their activities.
Yes.
And impacts their ability to sleep, etc. And how do you tell if it's real? But in fact, your answers were really good there, and I hope that those are going to be very helpful to our clients.
Yeah.
So we had 2 people with questions around that. But the other question that I have actually came from a lawyer, and he wanted to know, how do pain specialists go about educating patients on what is a reasonable expectation for their pain moving forward, given that we come from a society where everyone wants it now. We want it perfectly, beautifully, and wonderfully with perfect white teeth and a chirpy look. How do we educate somebody who, by virtue of what can often be a catastrophic injury, is going to now have to live with some level of pain?
Yeah, very slowly. Very slowly. And again, that's that's right. That's an issue. I mean, someone's life can be turned upside down in 4.5 seconds, like it was for this gentleman here, and then and then from basically the next day, he is left with a life that bears very little semblance to the life he had yesterday. Yeah. And this is one of the strengths of a multidisciplinary team, as I described it, because we all see the patient, we see them together, we see them individually. We all have a consistent message, or we should all have a consistent message. Everyone approaches the education from a slightly different point of view. And it's just a matter of basically explaining what pain is, how it transitions from acute to chronic, explaining some of the risk factors and reflecting it back to the patient, explaining what is it about them that's predisposed them to this, and then just gently reinforcing that message over time. Yeah, it is a journey, and there'll be a significant proportion of people who will who fail to accept that, unfortunately. Yeah.
Mhm.
And
And
then end up on a merry-go-round of seeing various specialists, investigations that are probably not warranted, surgery that is probably not warranted. Not saying surgery is never warranted, but they just end up on this vicious circle of seeking a cure. Okay,
mm,
and part of our job is well, part of my job, I think, is explaining to the person that in 2024 we can manage their pain, we can improve their lived experience, we can improve their function, but the actual persistent pain side of things is not something that we may be able to completely eliminate, and that takes time, Michelle.
mm.
Yeah.
Does anyone else have questions that they would like to ask of Dr. Slava Poel?
Michelle, can I just go back? Sorry, if
Yeah.
just back to the nausoplastic pain. So yeah, so
Yeah.
nausoplastic pain is a tricky one. It's a new diagnosis, and I see when I read some IME reports from specialists who are not pain specialists, I can see they really struggle with that. Okay, because it's quite an unusual kind of presentation. The pain does not conform to any kind of anatomical structures. It's the limb may be very sensitive to touch, sensitive to movement, and it's just a pain that makes no sense. Now, there are actual diagnostic criteria by which you can diagnose this pain. Okay, so it's not left to the individual to decide whether it's present or not. There are actual criteria based on the history and physical examination. So there are objective criteria for identifying nausoplastic pain. Yeah.
Thank you. Two last questions. One is that in the management of pain, we're seeing an epidemic of people doctor shopping for opiates and other forms of pain medication, tablets in particular. We're seeing restrictions on the number of tablets per packet and the number of scripts, etc. How do pain specialists manage people who develop an opiate addiction or even a perceived opiate addiction?
Yeah. Yeah, it can be very tricky, Michelle. So unfortunately, the same people who are at risk of developing chronic pain, okay, these are the same people who are at risk of developing opioid dependence and addiction. There's quite a large overlap, which is why if you look at the population, the addiction population, opioid addiction population, the chronic pain is reported depending on where you look, by 40 to 60% of patients. So there's a huge overlap. A lot of it will have to do with socioeconomic backgrounds. A lot of it will have to do with the type of childhood that patient has had. Okay. There's a term that we now use called complex opioid dependence. Okay, to describe people who actually need the opioids to function normally. Okay, so they've got an endogenous or innate deficiency of the opioids, and so they have to rely on exogenous opioids, meaning opioids taken in a tablet form and an injection, just to be able to function normally, just to be able to regulate their mood, regulate their stress. And these are the people that we often see get into trouble with pain and opioid dependence. So the first step is to identify it, obviously, and there are some behaviors that we can identify. Dr. Shopping is one of them. There is a real-time prescription monitoring service. So in Victoria, it's called Safe Scripts, where any doctor can log in and actually have a look how often the patient's been prescribed opioids, how many types of opioids. This goes for sedatives as well, like diazepam and Valium. How often they've been prescribed, with how many doctors are prescribing at the same time. And this service also sends doctor's notifications as well. So there is so this type of behavior leaves a trail basically, and you can follow it. Having identified it, the next step is obviously to address it, and in that instance, we will often rely on our drug and alcohol or addiction specialist colleagues. Okay, provided that the patient wants to engage. You see, so it can be quite a difficult dilemma.
Yeah, absolutely.
Before that step, however, it's useful to explain to the patient that there are other ways of treating their pain. We spend quite a bit of time explaining the risks of opioids, including the risk of tolerance, meaning that they'll eventually lose their effectiveness, risk of dependence, okay, whereby if they just continue taking these medications, it will become more and more difficult to stop them. And then the various effects on their mood, on their sleep, on their hormonal levels, even or immunity that these medications can have. So education is part of trying to redirect the person away from sort of opioid-based treatments towards a more holistic approach. But it's a battle. It is a battle.
Thank you so much. Last question is about those implantable stimulators or devices.
Yep.
When are those indicated?
Yep.
How efficacious do you believe those to be?
Yeah, that might take another hour.
Okay.
That alone. I've actually done a presentation on that. That took about an hour. So implantable devices have been around for a very long time. They've been in the public eye recently, but they've actually been around as a form of treatment for probably 40 years. I may be wrong. So they've been around for a while. There is now an explosion of different types of technologies and the companies that manufacture these technologies. There's been recent controversy with it was at 60 Minutes that has recently reported on the space. Look, if the short of it is, spinal cord stimulation is an invasive treatment that can work very well for very well selected patients, okay, for very well defined pain conditions, okay. So the most common pain condition that we use spinal cord stimulation for is something called post-laminectomy syndrome, or previously known as failed back syndrome. This is where a patient continues to report severe back and leg, or say neck and arm pain, having already had a technically successful surgery. That is probably the most common indication. There are others. CRPS is another one. And if the patient is well selected and the outcomes can be quite good. The selection process does involve more than just a pain specialist. It needs to involve a psychologist as well. Okay.
Lovely. Thank you so much. We do have to wrap up now. I think I speak for everyone in saying that that's actually been very, very interesting and very informative. So, Dr. Slava Poel, I thank you so much for your time and expertise today. Everyone, thank you for your time in attending. The recording and slides will come out to you hopefully by the end of today, but it might be tomorrow. And of course, the recording will be up on our MAG YouTube channel. We're getting some waves and some thank yous, Dr. Slava. And you can, if you have any further questions for Doctor, you can email them to me and I will make sure that we get an answer out to you. And if you have any other ideas for seminars, please let me know, because we'd love to get more of our wonderful specialists out there for you. Thank you, everybody. Go and have a great rest of the day.
Thank you, everyone.